So why is genetic testing important? Because we can diagnose LQTS from the ECG. So first of all, I'm not going to discuss it, but 1/4 of LQTS patients have a normal QTC. So we need to know the gene, how to treat the patient, and why is that? So for now, we have also more than 17 genes, so a lot of mutations, but most of them are dominated by LQT1, LQT2, and to some extent LQT3, but LQT1 and 2 dominate most of the genes. And we also can look at the phenotype, how the patient behaves beyond genetic testing, which is, we can look at QTC, we can look at whether the patient passed out, they had syncope, and we have to combine the genetic data with the clinical data. So there are, as I mentioned before, there are clinical risk factors for syncope, body cardiac arrest, and sudden cardiac death in patients with long QT syndrome. We know that sex affects the risk. Males between age 1 and 12, women after the onset of adolescence. The QTC interval, especially as I mentioned earlier, above 500 milliseconds. A history of syncope, especially recent syncope, with the past 2 years, is going to increase the risk of sudden cardiac death subsequently. So those are clinical risk factors: sex, age, QTC, and clinical history. And then we're going back to the genotype and the mutation. And as I mentioned earlier, there's LQT1 and LQT2, in which there's a slow leak of potassium. LQT3, there's increased leak of sodium, and this increases the QTC interval and increases the risk of life-threatening events. And we see, because of those specific mutations and specific effects on the ion channel, you see that in LQT3, there's a specific morphology to the QT interval. This is the QRS and the T, and here you see there's a delayed onset of the T wave. In LQT2, the T waves appear biphasic because of the slow potassium leak affecting the ion channel. In LQT1, you see those huge T waves. So even you will show you those EKGs, you can recognize which genotypes are associated with this genetic disorder. So you see, so those are actually, it's not one disease, it's multiple disease entities that have to be treated differently and re-stratified differently. And this is the reason that the clinical expression of the disease is different. In LQT1, because of the specific potassium channel effect, it's more affected by adrenaline and sympathetic activity during exercise. Excuse me. LQT2, it's a different effect of adrenaline associated with emotion. In LQT3, it's a different effect. During rest, even sleep, the heart works very slow, there's more bradycardia, the heart rate goes down, and then the sodium has more of an effect, increasing the risk of events in those patients. Any questions? Yes?
Can someone have more than one LQT? Like, can you have one and two?
Yes, so there are different. I think someone in the audience said that she has two. And once you have two, there's accentuation of the risk. You can have one LQT1, we can have even polymorphism, just general mutation in the gene. It may further increase the risk. And the gene that is associated with deafness that we saw earlier, there are two mutations in LQT1. So this actually doubles the risk in these patients. That's the reason those patients or the individual have a high risk even during childhood of having events. So two mutations increase the risk. If there are two different mutations, there's a certain increase in the risk. If there's two mutations that are identical, there's a very pronounced increase in the risk associated also with deafness. Yes?
Can a mother have type 2 and pass on to their child either 1 or 3? Or
No.
will it stay always 2?
It has to be stay with two unless the father that is a silent carrier passes this to the child. But a mother cannot pass to the child something that she doesn't have. Yes?
So if my children were tested when they were young, and it was and that was just not a genetic testing, it was just the electrocardiogram.
That's not enough.
That is not enough.
They,
So
they should be
just-
tested for the same mutation that you have at the least.
Okay, so that means they still could have it.
Yes, because as I mentioned, about 1/4 of those affected by genotype have a QTC below that is normal range. But if the genotype is a high-risk genotype, I'm not going to show that, there's still a certain risk for cardiac events, and they should be at least be protected with beta blockers. Yes?
Sorry. I had genetic testing in 2005, and it was determined I had long QT2. Did they automatically check for all the long QT, the different long QTs? Would they have back then, or would they stop once they determined I did have long QT2?
Usually, as a first test, when you don't look within the family for the same mutation, they do extensive testing. But right now, we identified more and more mutations, so as we get further, there may be some mutations that have not been tested in 2005 that are currently known. But I think usually most of the patients have just one mutation, so that's the major mutation that was identified. So right now, what we identify is more rare mutations that are more significant, are less significant. Yes?
Could there be more than one mutation?
There can be more mutation. That's the reason some of the people here have 2 mutations.
Within different members?
Yes, yes. But they are not being passed on by one person. They can be just transmitted by multiple people.
Thank you.
And now look what happens in the ion channel. Now we talked about that LQT1, LQT2, and LQT3 have a different risk, they have a different mechanism. But even in patients with LQT1, there can be different risk. Because here, we identified that those C loops, those that connect the ion channel, are more likely to be affected with adrenaline. So if a patient has a mutation in this area, this patient has a higher risk than a patient that has a mutation in this area. So, I'm sorry. We should not only look at LQT1 as a single entity, we should also look at where the mutation is located. And look here, those patients who have mutations in the C loops, those areas are more likely to be affected by sympathetic activity. Their risk of sudden cardiac death between birth and the age of 40 without beta blockers is 30%, as opposed to less than 10% of those who have mutation in the C, in the terminus or other regions of the ion channel. So it's not only the genotype, it's also where the mutations is located across the ion channel. That's the reason genetic testing is even further important. And those C loops are very sensitive to sympathetic activity and adrenaline. That's the reason patients who have mutations in the C loop region are even more protective with beta blockers as compared to other patients. So there's genotype and mutation-specific therapy in this entity. And that's the reason LQT1, we still don't know why LQT1 males have a higher risk, but that's the way we'll be able to further re-stratify patients by genotype and mutation location, because now we know that patients who had prior syncope, they have prolonged QT, they have C loops, or they are males, have a higher risk compared to those who don't have QTC, they have no C loops, and they are women in LQT1 without a history of syncope. On the other hand, in LQT2, there's a higher risk for potassium leaking out of the channel, slowly leaking, so those pore regions have a higher risk in LQT2. And look what happens. Women, patients who have long QT, LQT2, have a higher risk for cardiac events if they have a mutation in the pore region. Almost 60% risk in the increase in the risk of cardiac events if they have the long QT2 and a mutation in the pore region. Any question? This is getting more into basic science, but I want to make sure that you all understand this type of concept of not only the genotype, but where the mutation is located. I was talking about this region, the POR region.
It's called POR.
POR.
There is a, like you have a channel, and in this channel there is area which passes this ions, and this is, it's called POR, where through POR the ions are flowing.
Yeah. So this is, again, in LKT2, the problem is that potassium doesn't leak out as fast as should be out of the cell, so this POR region is more responsible for this effect. So if the mutation is here, located here, there's less likelihood of potassium getting out of the cell. And women are affected in LKT2 more than men, again, because this accentuation of estrogen on the potassium channel. And that's the reason we created a genotype-specific recertification in LKT2 that includes women at a high risk after the onset of adolescence, those who have a POR region mutation, QTC, and prior syncope. So you see that we can combine now the genotype, the mutation location, the age and sex, and clinical history to have a more comprehensive recertification and create a risk calculator that is being individualized and patient-specific rather than generalized. Yes?
Back to the slide where you were talking about increased risk depending on where the mutation was.
Yes.
If we had genetic testing done, we did, would that genetic test report that we have tell us where the mutation was?
You would usually get a mutation, but there's a report below the testing saying where the mutation was the risk, but you can always, because you're connected to us, you can always send us an email. We'll give you an answer where the mutation is located, and based on that, what we think the risk is. But usually with the report, you get some sort of indication how much the mutation is associated with risk.
Thank you.
And this is LKT2, but there's also increase in the risk of a LKT3 by mutation location. And we see that there are certain mutations. This is a mutation that we identified in a family in Israel. It's a very large family, several families, but they have almost no events as opposed to other mutations in LKT3 that are associated with high risk. So again, you see that beyond the genotype, we have to know some information about the location of the mutation and its function. And this is an example of LKT3 family from Iowa, why the importance of having genotype-specific testing. Because as you see, as I mentioned earlier, in LKT3, you see that there's delayed onset of the T wave because of this sodium leak that is continuing. But look what happens if we give sodium channel blockers. The QTC decreases, and flecainide or mexiletine that you are getting that is associated with a lot of side effects. Again, you know the flecainide is less associated with the side effect, but in any case, it decreases the QTC, especially in LKT3, and this is more of a genotype-specific therapy in LKT3 patients. And this is a study that we did, and we showed that there was a reduction by 100 milliseconds giving flecainide to an LKT3 patient. So now we can, in general, this is just a general description, we can propose an outline for genotype and even mutation-specific risk and therapy in LKTS patients. So let's take, for example, LKT1 patients. We learned that they are more affected by exercise and sympathetic activation. So we can create some lifestyle modification. It's not really restriction, but we can should be more careful about competitive sports and especially swimming. And then in low-risk patients, we can consider beta blockers. If a patient is at a higher risk, if the patient experiences symptoms on beta blockers, whether the patient has a C-loop mutation, very high-risk mutation, plus syncope, this patient should be considered for an ICD or sympathectomy, because we know that sympathectomy is affects the adrenaline surge on the heart. And if the patient's already experience a body cardiac arrest, this patient should get an ICD with beta blockers. In LKT2, there's also a suggestion for lifestyle modification. Again, should refrain and should be more careful from emotional responses, unexpected auditory stimuli, especially during rest of sleep. Beta blockers are slightly less effective in LQT2 because their effect is less on sympathetic activity associated with exercise. We should be careful about that. So we should everybody should be studied on beta blockers, but if there is a hint of residual symptoms on beta blocker therapy, like syncope, these patients should be carefully considered for an ICD. Patients who have POR mutations with symptoms, patients who have recurrent symptoms, syncope on beta blocker should also be considered for an ICD. And again, secondary prevention. In LQT3, we should be more careful about children having events during sleep. There's limited data on beta blockers. There is response the response may be sex specific. We should consider even giving sodium channel blockers to LQT3 patients and assess the QTc response to flecainide or mexiletine. In high-risk patients, by mutations, by clinical symptoms, should be considered for an ICD, or those already experience a body cardiac arrest or sudden cardiac death. Again, these are general outlines, but now you can see how we can use the genetic data to further improve therapy and have therapy that is QTc specific and genotype specific in LQTS patients. Thank you.
Any questions?
Dr. Goldberg, could you go back 2 slides, LPT? Yeah. There you go.
But everything is going to be posted at the website.
I know, it's for our flight now.
I know. Even my voice is going to be there, your questions, everything. And everything that you need in the article and the questions is always going to be available.
So if I could ask you this one, I've got my children's genetic testing right here.
And it's I can't pronounce these words. The C.2765DELG pathogenic mutation located in coding exon 12 of the KCHN2 gene results from a deletion of one nucleotide at nucleotide position 2766, causing a transit.
Send it to us and we'll respond to you carefully, because you see there are thousands of mutations here. I'm talking about a region, and if they're saying it's in the N terminus or C terminus, it may be low risk. If it's located in a transmembrane, I'm not sure what's the specific mutation that you mentioned.
So let me only comment that those numbers which you have is the position of these nucleotides throughout. So it starts with 1 on the left, goes to 1159. This is how the channel is composed. And the POR region, which Dr. Kallenberg was speaking about, is this. These are kind of like domains, 6 domains go from S1 to S6. And the one which passes this potassium ions is between S5 and 6. And he pointed out 552, which is pretty much beginning of this region,
Yeah.
up to 657, which is like end of the region. And you can look at the number in your test and see what is the number, whether it falls between 550 and 650 more.
Yeah.
So, but parents pass down only the same mutation
Yes.
to their children. There's
Yes.
not
No. Yeah.
So if one parent, they just drop
Yeah.
right down.
So you can even look at we can send you this picture and you can identify where the mutation located. But it's best for us even to point out, once you give us, we point out for the channel where it's located.
So are you getting better at identifying mutations, or are there new mutations happening?
We're getting better at identifying. But it's always new mutation happening in nature. We're going to have different diseases.